Hi, everybody. We're gonna get started. The people in the room, thank you for coming in person. To the thousands who are watching us online, thank you for being there. I'm Paul Applebaum. I'm from the Department of Psychiatry here at Columbia, and I have the pleasure of introducing our speaker this afternoon. Jennifer Wagner is Assistant Professor of Law, Policy, Engineering, and Anthropology at Penn State University. She has a BA in Anthropology from Penn State, a JD from the University of North Carolina Law School, and then she went back to Penn State to get her PhD in Anthropology in 2010. And her thesis was on the social and legal implications of DNA ancestry tests. So she's been focused in this area for a long time. After stints as a postdoc at Duke and at Penn, she spent a year as assistant professor of bioethics here in New York at Einstein. And then from 2014 to 2015 was a AAAS Congressional Science and Engineering Fellow working in the office of Senator Ed Markey in the US Senate. Following that stint, she spent 6 years as an assistant professor and director of bioethics research at Geisinger. And since 2021 has been back at Penn State in her current roles. Jen has written widely on LC issues in genetics and other technologies. And she is currently PI on an NIH grant looking at the bioethical, legal, and anthropological studies of new technology. So her interests are broad, her training is broad, and we're delighted to have her with us today. She's going to be speaking on privacy and access, examining constraints on information flows for precision health. Jen, thank you so much for coming to New York to talk with us.
Thank you. It's a pleasure to be in New York. I like to come and eat in New York. It's great. And I look forward to doing that tonight. All right, so I'm going to share with you some research that was done actually with collaborators at Geisinger to some extent. And it is on privacy and access, examining constraints on information flows in precision health. Before I do that, just the usual disclaimers and disclosures, right? I have NIH grants. There was one that underlied this particular research that I'll be sharing today, which was an NCI grant. And I'm an attorney, but that's not what this is, right? This is me just sharing our research. So the parent project that led to this work was a collaboration involving Kaiser Permanente, Kaiser Mid-Atlantic, and Geisinger Health System, and its feasibility and assessment of a cascade traceback screening program with FACS, led by Alana Ram, who's now actually at NHGRI, Nora Hendrickson, and Mary Cobble-Jones. So I wanted to give them acknowledgement. And I also had assistance of 2 students. When I joined Penn State, 2 students helped me out with some of the work. So Juhi Tanaru, who's now a law student, and Courtney Chi. All right. So, oops. Sorry. Hopefully that's not too distracting. I don't know how I got that on there. Okay, so we were looking at assessing a legal pathway for implementing his cascade traceback screening program, particularly for ovarian cancer. And we were asking this specific question: does the public health exception to the HIPAA privacy rule, so the Health Insurance Portability and Accountability Act privacy rule, provide a viable pathway for the implementation of a traceback program for ovarian cancer? So we know that improving access to genomic risk information has been a growing priority with efforts advancing in both medicine as well as public health domains. The population health impact and cost effectiveness of those programs is premised on this trace-back cascade that at-risk relatives, right, at-risk first-degree relatives of probans are notified of their risk and invited for genetic testing themselves, right? However, uptake of traceback programs has been disappointingly low. We hear frustrations from genetic counselors about this frequently. And one barrier to the traceback program is this constraint, right, where it's traditionally run through the proband. So relying on the proband, encouraging the proband to communicate with at-risk relatives and share with them their information, tell them that there could be some benefits for them getting tested. Probands do not always appreciate, though, the importance of communicating that familial risk, and they might not appreciate how important it is to do so promptly and get tested. Sometimes they're apprehensive about having such conversations for whatever reason. And then other times they simply don't want to share their personal information with their family members or anyone else. And a particularly acute example of this general problem is in ovarian cancer. So this is a condition for which germline mutations in BRCA1 and 2 are known to increase one's risk, and for which multiple current clinical guidelines recommend genetic testing. Unfortunately, ovarian cancer is often detected too late to effectively treat, right? This means that both genetic testing of at-risk relatives is critical to support early intervention. And it also means, unfortunately, that probands often die before traceback testing can be broached. So this underscores that the approach that relies on a proband for cascade testing is problematic. I was among a team of scholars who examined HIPAA a few years back, particularly with regard to this need for clarification as to what could be done to improve access to genetic risk information. And that paper, which was also published in the Journal of Law and Biosciences, reflected that you could clarify this, you could try to improve access by, one, assisting probands with their communication with their relatives. You could provide them with prepared materials, for example. Two, you could directly contact at-risk relatives with the proband's authorization to do so. And three, you could indirectly contact their healthcare providers treating the at-risk relatives, even when you're lacking a proband's authorization. An open question at that time, though, was whether HIPAA would permit providers to directly contact at-risk relatives without the proband's authorization. This has been generally dismissed, or prior to our work, it had been generally dismissed without really taking a close examination of it. I mean, certainly people had been thinking about it, and they generally thought the answer was no. But we really wanted to look at how we might advance precision public health by allowing direct contact of at-risk relatives, even in instances when the proband authorization might not be available. And that was this public health exception. Okay. So using genetic cancer syndromes as our test case, we explored the contours of this health exception to see whether or not it might be viable. And there was a very, real and present need for this information, right? Geisinger at the time was trying to develop a way to implement a traceback program for these cancers. And so again, we were looking at three particular use cases, all right? So the first use case is where the proband has died and the genetic information is not yet available about the proband's cancer. As a reminder, for those of you who don't live and breathe HIPAA, the privacy rule protections do extend beyond death. They extend for 50 years. The second instance that we wanted to consider was that the proband is still alive, but the proband's whereabouts are unknown or contact information is not available, to provide a proband with an opportunity to authorize or object to the disclosure to at-risk relatives. So it's a situation where, maybe logistically it's difficult. Is there a way for us to nevertheless contact at-risk relatives? And then the third situation was the proband's alive and steadfastly refuses. Could be for a variety of reasons, but refuses to notify at-risk relatives personally or to authorize healthcare providers to do so on the proband's behalf, right? So what were we going to do here? How would we answer this question or try to find an answer? Well, we wanted to first look at public health exception to the HIPAA privacy rule itself. We wanted to look at the regulatory exception and then look at the regulatory history and perform a bit of a textual analysis. And I apologize for all the words on the screen, but this is what you get when you do legal research. I tried to at least highlight some important points and put excerpts here. But the header of this slide is telling you where you can find this particular public health exception to the privacy rule. And it says a covered entity may use or disclose protected health information without the written authorization of the individual or the opportunity for the individual to agree or object in situations covered by this section. And one of those sections is B, standard, uses and disclosures for public health activities. And here it says the covered entity may use or disclose protected health information for the public health activities and purposes described in this paragraph too. And then it gives you a list of who those disclosures can be to. And item number 4 says, to a person who may have been exposed to a communicable disease or may otherwise be at risk of contracting or spreading a disease or condition, if the covered entity or public health authority is authorized by law to notify such person as necessary in the conduct of a public health intervention or investigation. Okay, so from a textual analysis, I highlighted maybe some important concepts or aspects of that we need to parse out and get meaning for. Okay, so or may otherwise be at risk of contracting or spreading a disease or condition. Is genetic risk analogous to infectious disease risk? Right, the scale of spread is certainly different. Whether the conditions of the HIPAA public health exception would be satisfied and thus enable, that is, permit direct disclosure of genetic risk information to a proband's at-risk relatives to carry out a traceback program, requires us to find that the disclosure would be necessary as part of a public health intervention or activity or a public health investigation, as well as being authorized by law. Okay, and the evidence for such a finding theoretically would include documentation like a memorandum of understanding between the healthcare providers and the public health entity or the public health authority. So what does this authorized by law mean? Right, it's not defined by HIPAA. HIPAA actually does have a definition for required by law, but it doesn't have one for just authorized by law. So we know we have to look elsewhere. We have to look at another law. We can't just rely on HIPAA. And so here we're like, okay, well, there's language here that's suggestive that this might be a viable option, right? We need to clarify whether the conditions are going to be met, but you could, in theory, say, well, you might pass on, you might risk spreading a disease or condition to the next generation if you don't learn of your genetic risk information through a traceback program. And we could say this is for public health purpose. There have been piloting attempts to do so. That's a lot of the point of this is being able to reach people beyond the individual patient. But looking at the details is required, okay? And so we turn to the regulatory history, right? We looked for reassurance that applying the public health exception to genomic conditions would not clearly run counter to what the policymakers' intent was. And it's useful for us to look at this history, right? So HIPAA privacy rule was first proposed in 1999. It was not a party. It was a slog to get there. When it was issued in its final form in 2000, the Department of Health and Human Services actually referred to genetic and hereditary information dozens of times. Right, so they clearly knew that there was this thing called genetic risk information. They didn't call it out. They had an entire section actually that they devoted to advances in genetic sciences, and specifically considered privacy matters related to possible disclosures of genetic and hereditary information of deceased individuals and what that disclosure might mean in terms of health benefit for surviving individuals who are related. And they also considered the relevance of information about illnesses with a genetic component for the treatment of others. So not just the treatment of that individual, but for other people. So although the Department of Health and Human Services therefore clearly anticipated the applicability of HIPAA to genetic information, they rejected characterizations that this public health exception would be far too broad if it was interpreted in that way. There was a comment that it was an inappropriately broad loophole that they flat out rejected. And they also rejected suggestions that they should have the privacy rule impose limits on public health functions. They said, well, that's already done. We have established by law. You have to turn to some other law in order for it to be triggered. So they felt like they were keeping it sufficiently narrow to protect privacy interests while also allowing these public health purposes to move forward. They did explicitly decline to distinguish, and I'm quoting now, to distinguish between disclosure of information about communicable diseases and disclosure of genetic information in allowing disclosure of protected health information to healthcare providers for purposes of treatment, including treatment of persons other than the individual. Okay, so they were thinking about multiple people being potentially beneficiaries of genetic risk information. They weren't calling out genetic risk information and saying that it wasn't included. When they had the opportunity to modify the HIPAA privacy rule, and they did this in 2002 when they were considering changes specifically to the public health exception, and they also did it in 2013 with the Omnibus rule to implement the High-Tech Act and the Genetic Information Non-Discrimination Act. They did not take the opportunity to narrow it. They left it as is. So they had the opportunity, they rejected that. Our review of the regulatory history then leaves us with no evidence to suggest that this shouldn't apply to genetic information. We have no evidence that policymakers were distinguishing between horizontal transfers of disease risk and vertical transmissions of disease risks, or were interested in modifying the privacy rule to preclude genetic risk information from being disclosed if the public health exception would otherwise be available. So this all looks somewhat promising, at least to start, right? So we're saying that we can't rule out that this would be applicable, that this would be a viable pathway. We still need to see if those other conditions are met. So we turn to this concept of authorized by law to notify. What does this mean? We need to find out if, excuse me, to know whether notification has been authorized by law. We examined a couple of different places. So for us, we looked at the National Notifiable Diseases Surveillance System. We looked at their list of reportable conditions. We also looked at the regulatory frameworks for the 50 states and District of Columbia and the US territories that we could access for genetic conditions, and specifically our use case involving ovarian cancer. We considered two separate lists to determine whether a condition was genetic when we were looking for these examples. We didn't want to rely just on our own interpretation of what a genetic condition would be. We didn't want to rely on friends that we know who have medical degrees. We wanted an independent way to search this, and we wanted two. We turned to the list of genetic conditions on the Genetics Home Reference website, which during our study actually got absorbed into Medline Plus. So it's now in that Medline Plus system. But we looked at their list. This list contains more than 1,300 conditions, so it's quite broad. And the second list that we turned to were the list of genetic disorders that were posted on the National Human Genome Research Institute's website. When they were explaining to the public what are genetic diseases, they had this list. And we considered that first list, the Medline Plus list, to be pretty liberal, pretty broad. Anything that might have a genetic component, we considered the latter list to be quite conservative. So that was one approach that we took. In addition to this primary approach, we also learned that the Council of State and Territorial Epidemiologists, that's the body that determines every year which conditions are nationally notifiable. We learned that they maintain a searchable database. And so we went to their searchable database and performed searches there. This identified 31 jurisdictions with explicit cancer reporting requirements for healthcare providers. So there, I'll get into the distinction here in a second about reporting and notifying, but we did find that there were conditions on the list. So just a summary of what we were finding now. So if we look at the genetic conditions for the NHGRI website, we see breast cancer, colon cancer, prostate cancer, skin cancer, hemophilia, PKU, and sickle cell disease in particular states. These are reportable. So we also found, per the Genetic Blueprints website, a number of states where genetic conditions were listed. So the National Notifiable Disease Surveillance System was found to include two conditions that appeared on the NHGRI list: cancer and Kawasaki syndrome. I already told you the 8 conditions that were listed on the NHGRI website right here. We also found the National Notifiable Disease Surveillance System list included 6 conditions that were on the GHR, listed as genetic, those are shown here, and 15 conditions that are on the genetic reference list as having a genetic basis that were observed on one or more reportable conditions lists. Okay. I'll make a point about that. So these genetic conditions are already appearing on these lists. That does not mean that their genetic basis is why they're on that list. But in any case, revisiting the text of the HIPAA public health exception that permits disclosure to those individuals who might otherwise be at risk of contracting or spreading a disease or condition, the appearance of genetic conditions on the state reportable conditions list, those things arguably support this as a viable pathway, but we can't stop there. We could, sorry, I'm having trouble reading my notes. We need to look at whether or not, even if it is authorized by law, there are other laws that basically would block that from happening. So we need to review various privacy laws, various statutes that might apply, because HIPAA sets the protective floor, right? HIPAA is a federal law. It's going to preclude, it's going to preempt activities that are in conflict unless they're raising that requirement, right? Providing more protections, not lowering them. And so even in the rare case of a conflict, the specific exception to the HIPAA preemption is for a state law that relates to the privacy of individually identifiable health information. And that's when it's more stringent, right? So they're, again, intending to keep these laws to protect the privacy of the individual and put constraints on those information flows. This was the summary table that we published in our article. This work was done in May of 2022, and I will say it most definitely is outdated. I haven't gone back and looked at every single one of the states, but this is summarizing what we found at various points. But there are laws that have been moving quite rapidly. But in any case, at that time, we were finding there really wasn't anything that was preventing this from happening, except we weren't finding that clear authorization to notify. So we might have the situation where there was enough authorized by law where the healthcare provider needed to report it to the public health authority, but there wasn't enough to actually notify individuals that were at risk. So what we concluded with that initial assessment was that, does the public health exception to the HIPAA privacy rule provide a viable pathway for implementation of a traceback program for ovarian cancer? No, it didn't in 2022, and I'm sure it's not doing it in 2024, given how the laws have been changing. If we were to want to create a viable pathway for this to happen, if we wanted to use the public health exception as a means to implement traceback, we would not need to change HIPAA itself. We would not need federal legislation. You could do it now, but you would need at least clarifying guidance from the Department of Health and Human Services that they envision this being used in this manner. You'd also need to remove 3 different obstacles. Okay, you would need clear legislative or regulatory language in the state laws that authorize healthcare providers to notify at-risk relatives of genetic risk information as needed, right? That necessary component. Is that really the necessary piece for an intervention? You need to reconcile all of those state authorizations by law with any distinct information privacy law constraints on genetic risk information disclosures. And as I mentioned, issuance of clear documentation of the precision public health intervention or investigation. So if you are thinking about the distinction between healthcare and public health, one of them is who's initiating that, right? A healthcare system certainly can be and is involved in public health. We've seen that with COVID, certainly. But whether or not there is documentation of, say, a public health authority saying, okay, we are relying on you for this intervention. This is important. It's a public health priority. And you may, on our behalf, as part of this intervention, disclose risk information to at-risk relatives for traceback testing. That would be quite helpful, right? So there are a number of reasons why legal departments at healthcare systems are not going to tell anyone to go ahead and move forward with the traceback program in this manner. But then the question is, even if we could, should we? Is this really what we should be doing? With informational privacy law in a constant state of flux and uncertainty, it is unlikely that we're going to see a broadening of any HIPAA privacy rule to enable increased data use and disclosures. We aren't going to see that garner strong political support right now. But we can revisit the 3 use cases that I mentioned earlier involving non-consensual disclosure to at-risk relatives. So in the case of a deceased proband, one could argue that the beneficiary of the information that otherwise might be compelled by an ethical duty to warn would become that surviving relative or those surviving relatives. And in that case, that interest might outweigh the privacy interests of a deceased individual. And when probands are not known to object to disclosure, the health interests of those at-risk relatives likely outweigh the risk of disclosure associated with the proband's confidentiality interests. We can go back and forth on that one. I know my colleague Michelle Meyer and I did quite a number of times. Genomic medicine providers should only use the minimum information necessary to warn at-risk relatives and encourage the uptake of cascade testing. And so there it raises this question of, do you actually have to disclose the genetic risk information of that relative in order to reach out directly to help care and encourage genetic testing of the at-risk relative? Maybe not. It might raise some eyebrows. How do you know I'm at risk? Why are you contacting me? How did I get selected for this? Maybe we need to test whether AI is going to select them for it and see what happens. The third use case that I mentioned for non-consensual disclosures to at-risk relatives, in which the health system is overriding a clearly capacitated no from the proband to disclose that risk information, is of course the hardest one to justify, right? If you know that they are against it, vehemently opposed to it, regardless of the reason, then that's complicated. We believe as part of our work that whether the disclosure is ethically permissible or obligatory is going to depend on multiple factors, including the factors that we identified, which were the magnitude of the risk to the relatives if they're variant positive. So obviously not just having a genetic basis for a condition might not be sufficient, right? We might be looking for something that raises the magnitude. The degree to which that risk can be mitigated through that disclosure, the reasons for the proband's refusal to disclose. What is it there? Can you work with them? Can you work on the relationship? Another factor would be whether the disclosure is likely to cause harm. And that harm could be to the proband, it could be to the relative, to their relationship, to others in that family or elsewhere. Another factor would be whether the provider could instead point to evidence in the relative's own medical history or social history, as opposed to the proband's genetic results to encourage genetic testing. And then finally, whether disclosure could be made without revealing the identity of the proband. So given our analysis of the ethical permissibility, at least in some cases, we consider or believe that the HIPAA privacy rules public health exception should be leveraged ethically and transparently to advance the goals of traceback programs in order to hopefully reduce morbidity and mortality associated with heritable cancers and probably many other conditions. Our focal point for this work was ovarian cancer, but we would consider really up for discussion any of the tier 1 CDC tier 1 conditions for that they should traceback programs should be evidence-based. They should be attuned to the quality issues and equity issues, and we would reasonably encourage inclusion of all of those. I'm going to move on just a little bit. I don't know where I am with time. I think I'm okay. While support for expanded use and disclosure of PHI under the HIPAA privacy rule might be hard to secure in the Dobbs era, leveraging existing legal frameworks is critical for improving public health genomics or precision public health and access to data and information. And there are some aspects that I just wanted to highlight related to some other work that I've done, right? Data privacy law in and out of the healthcare system is changing every day. Sorry, I had some that weren't on there. It's really changing rapidly. So when we entered 2023, we had just a few states that had comprehensive, what we would call comprehensive consumer privacy laws. By the end of 2023, we had a dozen, and there's a lot of activity happening. We expect this trend to continue. There are a few noteworthy points though, because it's easy to get caught up in, oh, well, they have this comprehensive data protection law. That must mean that the rules are different for the medical space also. Well, maybe not. So these comprehensive laws are actually targeting anything in the commercial space. Okay. And they're targeting commercial actors. It's important to keep in mind that these laws are not identical. They do not have identical definitions. They do not have identical reach. There are some generalities. They generally do include genetic data or genetic information within the scope of what they're trying to protect. They usually include this as part of definitions for sensitive data or sensitive personal information. They typically are designed to target for-profit entities. Okay. So that's relevant when we're thinking about how might they reach into the healthcare industry. If they're targeting only for-profit entities, that raises some initial questions. Secondly, they were drafted with intentionality so that they wouldn't conflict with HIPAA. They weren't trying to interfere with HIPAA or the HITECH Act. They weren't trying to interfere with the common rule regulations for research involving human participants. However, they accomplished this in different ways. And this is where kind of the rubber meets the road. There are going to be some problems. There's undoubtedly going to be some frustrations in compliance. So some states carve out exemptions at the entity level. Other states carve out the exemptions at the data level. And that raises some difficult decisions. So for example, California, Oregon, Delaware, and Colorado, their exemptions are at the data level. So if the data have to be protected under the HIPAA privacy rule, then they are outside of reach of their comprehensive data protection law. You have to comply with HIPAA. There's nothing else for you to do. By contrast, Virginia, Connecticut, Utah, Tennessee, Montana, Florida, Texas, Iowa, and Indiana, the exemptions are at the entity level. So if you are a HIPAA covered entity or business associate that has to comply with HIPAA, any of the data are outside of reach, not just the data that are controlled by HIPAA. And so this is somewhat problematic. We have questions now that will have to be raised about what's in the designated record set, what remains linked and identifiable. Once you get de-identified data, they lose the protections, right? And so what does that mean? I expect to see some cases and controversies related to compliance with this regard. I also think it's going to be particularly difficult when you have for-profit and not-for-profit entities collaborating, partnering up, even though HIPAA in theory is supposed to protect every copy, right? Every copy in any modality. But this is going to be an area where we'll need to think about how these laws relate to one another. Some of them have not taken effect yet, right? They're scheduled to take effect. So the carve-outs might potentially raise vertical conflicts, so conflicts between the state and the federal law, and they also might raise horizontal conflicts between, say, New York and California, or New York and Pennsylvania, or whatever state you're in. I'm particularly interested in this because of how it relates to biometric data protection. You might have seen in the news in Illinois, a recent case was decided at the end of last year involving the use of biometrics of healthcare employees. This was to get at basically locked cabinets for drug dispensing and things. They were using biometrics to ensure that just right people that who were authorized to access those for the care of individual were getting into them. And that decision, Mosby versus Engel Memorial Hospital, basically said, well, we're not gonna protect the biometric information of the employees in that instance. HIPAA applies. Because of the way the law was drafted, BIPA, the Biometric Information Privacy Act, is arguably the strongest biometrics law in the world, let alone the United States. But the way it was drafted with its carve out to HIPAA, when they parsed it for this particular issue, they said, no, HIPAA applies. So your biometric information, the fact that you didn't follow BIPA for purposes of these healthcare employees, they don't have the benefit of that law. So that biometric information, it's not the patient's. It's collected in a healthcare setting, sure, but it's not the patient's data. It's not PHI. So it's left in this no protection zone. So that's going to be a little bit tricky. I don't know if the legislature there will address that or not. But again, we're seeing the ways in which the information flows are being blocked or facilitated move in ways sometimes unpredictably. And we're going to see how this plays out as these laws get implemented. I think this is going to be particularly important as we're thinking about the applicability of these laws at the data or the entity level and portability, how it affects the right to access, how it affects the right to correct, delete, amend, port their data elsewhere. For health purposes or not health purposes. I'll flag just in case you're curious about some high level comparisons. I'm not going to walk through this chart, but the IAPP, the International Association of Privacy Professionals, provides some really nice resources to explain how these laws act. So I wanted to just share that exists. I don't think I need to explain what the Dobbs decision was. I will just highlight its implications for health equity and anything that's happening in a digital health space and precision health space. Actions that are taken in reliance of health information privacy or non-discrimination principles, it's dangerous times, quite honestly. So we'll need to pay attention to this. Data practices that are happening at the local and institutional level really should be studied closely. I think there's going to be some fascinating research in the next few years in this space. I mentioned earlier with regard to traceback that the Department of Health and Human Services could go a long way by providing some clarifying guidance or addressing this issue specifically. They are responding to the Dobbs issue related to how information is shared or not under exceptions to the privacy rule. They were not looking at the public health exception. They're looking at the law enforcement exception, and also the exception for required by law. And so they proposed actually changes to the privacy rule that would support reproductive healthcare privacy in that space. We expect, I mean, they're going through the 25,000 comments and making some revisions, but we expect that final rule to be issued soon, or I expect it to be issued soon. These modifications to the privacy rule, they could strengthen data privacy that would restrict the flow of information that's available potentially for precision health, depending on how they do it. And I did want to mention that one of the proposed changes here is to have a purpose-based prohibition, where even if another law seems to require disclosure, HIPAA would not permit that disclosure if it's for a non-health purpose. So that might be an interesting one to watch. So we'll have to wait and see there. We also are seeing state legislatures responding to Dobbs. So it's not just in this broader privacy law space, it's in this narrow reproductive health space. But Washington passed the My Health, My Data Act, April of last year. It goes into effect next month for most, although June for small businesses. It has, it is fairly impressive in how it deals with the datafied culture that we live in now. It recognizes that digital health data are all around us. They're not always in the HIPAA space, right? Data that we maybe don't even think of as health data could have health relevance. So this law is intended to fill that gap and make others who have health information, or what we might think of as health information, basically do the same thing we already require of entities, right? It makes them take privacy and security measures. And they do this by having a new definition called consumer health data. So consumer health data is personal information that is linked or reasonably linkable to a consumer. Okay, so we don't know if that's going to track in parallel with PHI or identifiable data, right? And they provide a non-exhaustive list of information that falls into that camp, and genetic data is one of those. It does have a HIPAA carve out. So that's important to keep in mind. I'm going to just briefly mention a couple of points before I close and open up for any questions. Other aspects of information flow that I see as really important in the next few years relate to interoperability and porting information and information blocking. All of these decisions about privacy and flow need to be contextualized, right? They require this kind of human-centered design. So the 21st Century Cures Act was intended to help us move data around, right? Even in ONC, the Office of National Coordinator, their online disclosures even say, quote, it was, among other things, established that sharing electronic health information is the expected norm in healthcare, right? This changing mindset of we want to share these data, we want to share this information so that it can be put to good use, and we need to stop interfering with that. So we have laws that are in place to help move the flow of information and data for genetic and other health information, but we're still seeing this health and science in conflict with privacy notions and access notions. Digital health technologies that create much of the data used in biomedical data science are now frustrating or potentially circumventing how our health information privacy policies were structured. What do I mean by that? Some of the work that I've not started yet, it's on the horizon for me, if I can find the right venue to do it, is looking at these data practices for the ongoing devices that are being created for precision medicine, for personalized medicine, like the continuous glucose monitor, the automated insulin delivery systems that are linked to apps, various digital health technologies that we have that can truly be life-changing are interesting from the standpoint that biotechnologies used to have to rely on the healthcare system to gain access to patient data. Now they don't have to do that. They can create the technology that generates the data and decide what the healthcare system gets, what data are being shared, what data are displayed, what proprietary portals are required to be used for their purposes. And a lot of us probably can remember, the data hoarding that occurred with Myriad and BRCA1 and 2, and how detrimental that was to others who were trying to determine their genetic risks. I'm seeing the same thing play out anecdotally in what I'm seeing with wearable technologies and some of these other biotechnologies. And so I think if left unchallenged and unchecked, the promise of data science to enable precision medicine will not come to fruition, particularly because of these proprietary anti-competitive urges. We're having the situation, it would be really unfortunate if not only can patients not have access to their data, the clinicians trying to help care for them don't have access to the data either, and it's all stuck somewhere in a corporate database. So interoperability is gonna be an issue that we need to grapple with, even as we're thinking about privacy. Information blocking has been a rule, but it hasn't been available to actually capture the ones that we think might be involved, or patients might have the perception are as being the actors that are involved in the blocking, right? So information blocking or data blocking, and the definition is when individuals or entities such as healthcare providers or IT vendors knowingly and unreasonably interfere with the exchange or use of health information. There are some exceptions to information blocking that make it okay for the data not to be made accessible. Two of those are privacy and security. Those are legit concerns, but they are often used as a pretext for other reasons. So we need to be worried about how those are implemented. And if we look at the enforcement data so far, the claims that have been raised about information blocking since the 21st Century Cures Act, what we see here is a breakdown of 83% of the claims that have been filed on the portal. And those are claims that could have an information blocking component. So it excludes the ones that people are submitting something, but it doesn't actually relate to information blocking. Of the 898 that have been filed, 747 were reported to have dealt with healthcare providers. And for healthcare providers, we don't even have a rule yet on how to disincentivize information blocking. That rule was just proposed just a few weeks ago. The penalties for health information exchanges or IT vendors could be up to $1 million in civil penalties per violation. So that's pretty hefty. What we're seeing as the potential disincentive for healthcare providers from information blocking is to use the Medicare Promoting Interoperability Program, the Medicare Shared Savings Program, and the merit-based incentive payment system as a means to kind of withhold financial incentives that they otherwise would get for those programs. So again, trying to encourage the flow, the access of information, but we're still having these privacy concerns. The approach that I take to my work and a thought that I want to leave you with is that we do not have to see privacy in conflict with health and science. They can coexist. In fact, I think that we need to find ways to have them move forward together. I think that's where we're going to have some magic happen and enable precision medicine. So with that, I will stop and take any questions.
So Jen, let me ask you, for the sake of the people
Sure.
online, and repeat the questions.
Yes, I can do that. Any questions? Yeah.
So this was really interesting. But I find it really interesting that like there's what's it called? Like they're contextualizing like whether or not it's ethical to release information based on the recipient as well. So like for instance, like like whether or not this information would, do any harm to them. But there are so many ways to like measure harm. So like, is there like a scale, like from 1 to 10, like what type of harm will this do to this patient? And so like, should I even, like, if they're on the lower end, then I can give information, but if they're on the higher end, then maybe not.
Yeah, so great question. So the question was about thinking about who the recipient of the information would be when you're making decisions about whether to disclose, not disclose, and how do we have a scale for harm, or how do we decide what harm's okay and what harm's too much? It's a really fantastic question, and I will say that even the courts don't know what to do with data harms. It's been really, really challenging because courts think of or judges, juries, like, right? You think about, well, if it's a physical injury, okay, conceptually we get that. Physical injury, harm, got it. If it's a financial injury, we usually can understand that. If it's anything else, it's messy. We don't really understand, like, we don't have a great way to articulate that in the court systems. Actually, there are two privacy law scholars, Daniel Citron and Nino Solov, who wrote what I would call the landmark law article on this topic. It's called Privacy Harms. And they articulate a typology of different harms that come from data access or privacy violations. That's really quite useful because it draws your attention to thinking about, you could have relational harms, you could have economic harms, you could have stigma, and you could have chilling effects that come out of this. And so they lay out a really nice framework there that I'd be happy to email you if you give me your email address. But yeah, it's really challenging to come up with the type of harm and the threshold.
Regarding the disclosure, I guess I'm a bit confused. If you are disclosing that someone is at risk for a genetic disease without disclosing who is their family member, then it's okay now, or it's still not okay?
So right now, there are different instances that you can do, right? You can help the proband, like encourage the proband, give them materials, say, here's a letter. Please share this letter with your family members, and it lays everything out. Or it might say, please contact us, someone will explain it for you. And so you can have materials that help facilitate that communication between the proband and their relatives. You can try to get their authorization. If you have their authorization, you can reach out directly to the at-risk relatives and share the information that needs to be shared. Or you can give the information to another healthcare provider that's providing care for that at-risk relative. So it's like the indirect channel. You can't tell the person directly. You have to go down, the lane, whisper down the lane, tell the healthcare provider.
Similar, I guess, in the Geisinger format, but in places like New York, when you don't know where the relatives live and who are their providers.
So it can be really, right, it can get really challenging even within a Geisinger system, where I will tell you, so a lot of my work was with patient engagement and community engagement. When you go to a Geisinger clinic, a lot of individuals think my information is staying in that building. It's not leaving that clinic room. Yes, it might be on that computer, but the idea of cloud computing or modern precision medicine, modern healthcare system that is so heavily reliant on data, that's not what most of their patient population is thinking about. And so it raises these challenging issues of even if you were allowed under this public health exception, which again, we don't think that you are. Our assessment is that you cannot. We need to have changes in order for that to happen. We think that should happen, but you can't at the moment.
So your understanding is right now we cannot, even if we don't disclose who is the proband who has the risk. If you just say, I was informed that you have.
So
I don't know who.
So I think that I should back up and say, I know that New York has some special state laws, and I am not a licensed attorney in the state of New York. So please contact your attorney or legal department. So you would want to look at the state laws to make sure as to what they dictate here. If it's more protective, which I believe it is in New York, then you can't just rely on HIPAA anyway. The other thing is that the HIPAA provision would be, it works in a permissible way. So even if it allows it, it wouldn't require you to make that disclosure. Now to the other question, which is not the other aspect of my answer is not legal. It's anthropological. It's about the people, right? If you're told, I've been informed that you're at high risk or you're at high risk, the usual response is how, who told you? Why am I at high risk, right? You ask questions. That lack of information, there's an informational need there that will cause some sort of problem inevitably, either with their believing what you're telling them or trusting you to keep their health information private. And so it causes these challenges over what level of information is enough to do the job when what you want it to do is get tested. So could you establish protocols where you get this Provans information, you know that they're at-risk relatives, it triggers an investigation in your system of, is there something in that at-risk relatives chart that we could use with, now that we have this kind of information about the proband, now looking at their chart, is there something there that you can point to say, we've reviewed your chart and we think you're at higher risk, please come get tested or let us talk to you about testing. Is there something else that would cause you to reach out? But yeah, at the moment, it's probably in your best interest just to try to work with the proband and get through it that way. So
Jared, let me ask. We've all heard anecdotes about people who have refused to permit disclosure of information that might be genetic information that might be useful to their relatives. Are there any data at all that tell us how frequently this issue occurs?
So the question was related to, we've heard anecdotes of people refusing to tell their relatives. Is there any data? Is there any empirical data about how frequently this occurs? I don't know of any. It would be great to have that data, right? If you could have some sort of observational study and follow that and track that, that would be really, really important. I'm trying to think if Geisinger, I'll have to check with Adam Buchanan and see if they're tracking that. I know that they were tracking, like that was the goal behind a lot of the projects that we were doing at Geisinger, was to just, follow, see what happens, keep track of what's going on. But I don't know if they've synthesized that.
Because if the numbers are small, that suggests that the effort that would be required to change the status quo might not be worth it. If the numbers are large, you come to a very different conclusion.
That's right. That's right. Yeah. And I should say that these kinds of traceback programs, I mean, they've been piloted before. People have seen the value and have tried to figure out how can we actually make this happen? Could we get around this by actually having public health authorities employ genetic counselors directly for this purpose? That would be a way around it. The problem is the resource question, right? They don't have, they can't have they don't have the resources to have competitive salaries to hire best genetic counselors or retain them. And then the other aspect of that is, how do you account for those downstream expenses of the people that you're actually reaching out to in that setting? So it's not an easy thing to accomplish, for sure.
Yeah, so my question is kind of related to something you've touched on a little bit in a few of the answers to the last few questions, but you talked about, in response to an earlier question, about the distinction between the question of whether it's permissible and the question of whether it's required or there's an obligation to do it, the disclosure. And I think that seems to me like a really key issue, because the framing the discussion around whether people are allowed to do this kind of almost suggests that out there in the world, people are in healthcare systems, there are people who are just like itching to take on the obligation of tracking down everyone's family members and notifying them of their genetic risk. And in fact, I would guess that in many, I don't know how it works in Geisinger, but in Colombia and most medical record systems that I have, clinical apparatuses that I've had exposure to, it's not so easy to it's not just click a button and here's all the people in the world who have which and how genetically related they are to this proband. So I mean, even if that were the case, I don't know that people would be itching to take that on take on that obligation, but it seems to me like there, it's I guess I'm just wondering, like, how feasible would it even be to, you talked about how these trade back programs have been piloted in some instances, but I just wonder, in our system such as it is, if that's even a good word to use to describe it, how feasible would it even be to, if it were permissible, how likely is it that it would happen, and how would it happen?
Yeah, so the question is about feasibility. How, even if you wanted to do this, how could you accomplish it? It's not like you can just touch a button and you suddenly know who's related to whom and all of the details that you need. Yeah, the practical aspects are huge. I think the interest is that if you are a system like Geisinger, where there are families that are in for generations, you're there, you get your care there, your children get their care there, their children get their care there. In theory, it could be easier there than anywhere else. Or Sweden. But the issue then, why I pointed at this permissive aspect of the HIPAA public health exception is that it's not telling every healthcare system, you must do this, you must take this on, this must be your first priority. They're not doing that. This is a situation of, if you did have the means at your system, if the ideal conditions were there, if you had the software architecture in place that would allow you to do that, you might be allowed to do that. Provided, of course, it's authorized by law and not precluded by another genetic privacy law or general data privacy law. So there are a lot of ifs there. I think, oh goodness, going back more than a decade ago, I was talking about we have joint bank records. Why don't we have joint genetic information records? It's not just about one individual, it's about multiple individuals. So thinking about that in different ways, like we're stuck in this software system, we can engineer our ways out of that if we wanted to. I'm not saying that's an easy task or a cheap task, but you raise the issue of communicating even within a system can be quite complicated. I didn't give you the figures there. A survey was done in 2019 of healthcare systems in terms of how well they think they're doing in sharing information even within their system. And only about a third of those surveyed said they do it quite well. They're highly successful at sharing information within their own healthcare system. So that's why we still need laws like 21st century cures and different modes to help promote interoperability, to allow people to port their data wherever they are going. We're a global society. We need to be able to take our records with us. And again, privacy and security are often kind of reasons why that's not provided. But we need to make sure that it's made easier, right? The data need to work for us.
Just to build on that comment, where do you stop? First degree relatives, second degree, third degree? How far down the family tree do you go? Because in theory, there's some degree of risk associated with all of them.
Yeah, for our purposes, we were thinking about first degree relatives. We felt pretty good about that. So that's the scenario that we chose. There was a chat. I don't know if that's a question. Oh no, please put your questions in the chat. So I guess we don't have a question.
We're a little over, and if you are willing to say.
I'm willing
Chat
to
with people,
answer.
we can
Sure.
do that, but I should probably thank you.
Thank you.
Bring the formal ceremony.
Thank you.